Hey y'all, welcome back for another episode of MDTRIBE. This week we have an amazing interview with Dr. Kathryn Winn, who is an attending neonatologist at the Orlando, Florida Winnie Palmer Hospital, which is the largest NICU in the United States. Pretty insane. She saves all the tiny humans from 22 to 25 weeks, which is extremely small and extremely stressful. Like, that's all I can think of. But she shares her experience in her day-to-day life, what's so rewarding about it, what is very challenging about it, and kind of how she navigates that on a day-to-day basis. She's also an expecting mother, and she shares her experience and how that's kind of changed her perspective as well, especially now during the COVID-19 pandemic. She shares her experience couples matching with her husband, who is also a physician who they met in FSU Com as well. So that's really cool. But she shares her experience about what set her apart as an applicant in pediatrics and why she decided to go into neonatology and what she loves about her job and about all the tiny little humans that she saves. So I'm really excited for y'all to hear it directly from her. So without further ado, here's MDTRIBE. Episode of MDTRIBE. This week we have Dr. Winn, and I'm really excited to have you here today. So without further ado, can you please go ahead and tell us a little bit about yourself?
Hi, thank you for having me. My name is Kathryn Winn. I am an FSU Com alumni. I went there, graduated in 2013, was at the Sarasota campus, and now I'm an attending neonatologist at Winnie Palmer Hospital in Orlando, Florida.
Awesome. Okay, so we're going to start from the very beginning, starting with your journey to medicine. Okay. So when did you first know you wanted to become a physician?
Probably in high school. Everybody in my family is either a teacher or an attorney, and I knew I didn't have enough patience to be a teacher, so I assumed that I would go into law, and I took a law studies elective course in my sophomore or junior year of high school and thought it was just the most boring thing that had ever happened. And so I figured I better come up with a new plan. And that's when I took an anatomy and physiology class and started doing some shadowing and got more and more interested in medicine kind of my junior and senior year of high school.
And you said that you don't have enough patience for teaching, but as a physician, I'm sure you do a lot of teaching.
We do, but it tends to be a little bit more fast-paced and kind of on the go. I also have a pretty short attention span, which works really well with the ICU and with teaching in the ICU because it's so much more off the cuff and at the bedside than formal sit-down didactics.
Oh, okay. That makes sense. So a lot of your family, you said, did careers that weren't in medicine. What was your experience like applying to medical school then?
Actually, that might have been the hardest part just because I had no frame of reference. A couple of my friends were going through the same thing, but they all had family that were in the realm of medicine, and I did not. So I felt like I was flying blind a little bit. I had to rely on books and websites and guidance counselors at my undergrad institution. So I think really navigating the admissions process for acceptance into medical school is one of the biggest challenges that I ran into. I just didn't know what to do and what came next. I didn't have contacts, but obviously made it somehow.
Yeah. And did you take any gap years when you were applying to medical school?
I did not. I had actually half intended to. I had actually applied to just 3 or 4 medical schools my senior year of undergrad and had applied also for a master's program, kind of assuming that that's the route that I would go. But then got into FSU, loved the program, and so forfeited my acceptance to the master's program and went straight in.
Okay. Just out of curiosity, which master's programs did you apply to?
It was at USF.
Okay, that's the program I did. So
yeah, it looked really cool. But once I got into FSU, I loved their curriculum, I loved their mission, and couldn't pass up the opportunity.
Definitely. I kind of had a similar experience. However, so I started the master's program and applied to medical school.
Yeah.
And then once I was admitted to medical school, I dropped out of the master's.
I felt really bad when I emailed them. I was like, I'm so sorry. I got into medical school. I'm going to have to give up my spot. And they're like, you got into medical school. That's great. And I was like, I'm so sorry though. I felt so bad.
Yeah. And when you were applying to medical school and you started medical school, what did you first imagine that you would do as a specialty?
I was pretty certain that it was going to be in the realm of pediatrics or in surgery. I had always liked working with kids, and most of my volunteer work in the realm of medicine had been with pediatric subspecialties, but I also knew that I had that shorter attention span and liked to do lots of procedures, be very hands-on. And so the other realm that very much interested me was surgery. And so going in, I kind of thought it would probably be one of those two realms, which are very different from each other.
I'm kind of finding myself in the same predicament. How did you end up deciphering like going into peds or going into a surgical specialty?
Yeah. So when it came down to it for me, that's exactly the decision that I thought I was going to have to make was exactly the one I thought I did. I went through third year in my core rotations, and the two that I loved were the pediatric subspecialties and surgery. And so then I tried to think a little bit more about kind of the training and how to get to the actual job that I wanted. I really liked surgery, but I figured that if I went into surgery, I wanted to probably be pediatric surgery. And so I tried to think about the steps that I would have to take to get me to there. Part of it was how competitive pediatric surgical fellowships can be, that if for some reason my life didn't take me down that road, I was going to have to take care of grown-ups for the rest of my life. And so ultimately decided that there was more pathways to a career that I would find fulfilling coming from peds than coming from surgery.
Okay. If you had gone into peds, is there a way to go into surgery through peds?
I don't believe so, not anymore. I think you have to do surgery and then peds, as opposed to every other pediatric subspecialty where it's peds and then that subspecialty.
Okay, gotcha. Awesome. And what was your experience like at Sarasota, at the Sarasota campus, and kind of like deciding, that you were going to go into peds? Did that help a lot?
It did. I loved Sarasota. I was at Sarasota, and then my now husband, also an FSU Comm alum, was at Fort Pierce. And so while those two cities are incredibly different, our experience was similar in some ways. At FSU, at the time that I was there, there were no residencies, no fellowships, nothing like that. And so for each one of my core rotations, I worked one-on-one with my attending. And I felt like that gives a really different perspective on both the practice of that subspecialty as well as work-life balance. You get to really kind of pick the brain of your attending a lot more easily. And so being there and not having anyone between my attending and myself was very, very eye-opening. I had the opportunity to work with, of course, surgeons, pediatricians, med peds, internal medicine, and then actually was able to do a subspecialty rotation in the NICU there in Sarasota. And again, working one-on-one with my attendings, talking to them every day, trying to figure out what their actual life was like, as opposed to just what that subspecialty looks like on paper.
Yeah. Did you happen to do any away rotations?
I did. In third year, I spent 3 weeks in Immokalee at our campus there doing kind of a community health rotation. But then as far as real away electives, I did one at Fort Pierce in anesthesia, and then I did one at Arnold Palmer here in Orlando with the pediatric hospitalist groups.
Okay, awesome. Do you feel like that helped you stand out when you were applying to residency?
I think it helped me at those institutions. Certainly when I interviewed at Arnold Palmer for peds, I knew a lot of people there. I had contacts. I had letters of recommendation written from some of the attendings on that service, and I think that was very helpful. But I do think that in applying in general, having away rotations does make you seem more well-rounded, like you've experienced different hospital systems, experienced different ways of practicing medicine, and obviously having letters of recommendation from physicians outside of your institutions can sometimes seem a little less biased.
Okay, that's awesome. And would you say for pediatrics, for residency applications, that the letters of recommendation holds a lot of weight?
I do. I do believe that. Um, Coming from being on the other side of it and being part of the admissions process, interviewing applicants during both my residency, my PEDS residency, and then again in my fellowship, certainly there's some thresholds that many institutions will enact to decide who they're going to interview. But when it really comes down to deciding who of all of the qualified applicants is going to get an interview extended to them, or when it comes down to 2 or 3 very qualified applicants, which one are they going to extend or list higher, rank higher? The interview and your letters of recommendation, I think, are the most important part.
Oh, wow. Okay. When you were matching to your regional campus, was Sarasota your first pick?
It was, yes. My family's from St. Pete, and so I wasn't entirely sure where life was going to take me for residency and the fellowship that I assumed that I would do after. And so I wanted the opportunity to be close to them for a couple of years. Also, who doesn't love Sarasota? So yes, it was my first choice, and actually it was also my husband's first choice, but he didn't get it. So he ended up in Fort Pierce, which is another great campus, beautiful area. But I loved being in Sarasota. The physicians there, the hospital systems there, and of course just the area are awesome.
Yeah. So with you and your husband, did you guys have to do the long distance for the 2 years? Oh, wow.
Yeah, we had actually just started dating like 6 months before we went to regional campuses, and so we were pretty early in our relationship. But we did long distance for the 2 years. We saw each other about every 4 to 6 weeks, and that was part of we kind of planned our couple of away rotations. I had gone to Fort Pierce for that anesthesia rotation so we could actually hang out and make sure we liked each other. When I was in Orlando for my AI, he actually also did an acting internship with an internal medicine program here. So again, we got to be in the same place for like 4 to 6 weeks and decide whether or not we could actually put up with each other for that long. And then from there made the decision about whether or not we would couples match.
Oh, wow. Okay. Did you end up couples matching?
We did. We did. Yes, we decided we could, in fact, put up with each other for extended periods of time. And so we couples matched. He went into internal medicine and I did PEDS. And we were able to kind of arrange our interview schedule so that we got to go and travel to a lot of these places together. And we often would stack our interviews one after the other. So we'd spend 2 or 3 days in a particular city and get a chance to explore a little bit. And then got to create a joint rank list, which is maybe the hardest thing I've ever done.
I always hear the story about like couples matching and the ranking and how they go on vacation for a certain amount of days because you interview all over the country, and I think it's the coolest thing, but also I can't imagine how stressful.
It was weird. Fortunately, when interviews were being extended, I was on an emergency medicine rotation, so it was slightly less structured. And so I just walked around with like a calendar in one pocket and a map of the Southeast in another pocket. And whenever he or I would get an interview offer, we would text each other, and I would look at my calendar and look at my map and be like, okay, we're going to be in the Carolinas on this week. Could you get it scheduled that week? That would be great. And so it turned into this whole color-coded, super organized craziness. But what resulted was actually a really cool road trip where we flew to Charlotte, rented a car, and then we drove through and we did, I think, 6 or 8 interviews each, kind of on our way back to Florida.
Oh, very cool.
Yeah, it was pretty fun, actually.
That sounds like fun. What was your experience like applying to residency? Did you go into it feeling confident, or were you nervous? Like, can you tell us a little bit about that?
I think you're always nervous no matter what kind of an interview you're doing, and I think that's probably good. There's probably a reason why you're nervous, but I also knew that coming from FSU, we had really strong both didactic training and clinical training. As I mentioned, working with the regional campus system, you get a lot more one-on-one attention, I think, both from your particular attendings or residents and fellows that you're working with, and from your clinical teachers back at the campus. And so having all of that, I feel like we come out very well-rounded and very well-trained. And I put a lot of faith into that. but at the same time, I was definitely nervous at every single interview.
Yeah. When you were ranking the places, did you think that you would end up back in South Florida or Central Florida?
When we started interviewing, Patrick and I assumed that we would be ranking Florida locations as our first choice. That was kind of our plan. We were both born and raised in Florida. We never planned to leave Florida ever. That was part of what drew us to FSU. He was from the Fort Myers area and had gone UF and FSU, and I'm from St. Pete and went UF FSU. And so we both were very much on the same page about that when we started interviewing. We thought, we'll interview at all these places because we're couples matching and we have to be careful. So we'll go all throughout the Southeast, but at the end of the day, we're going to probably be ranking one of these 4 programs first. And then actually we went to Charlotte, North Carolina, which was both of our first interview, and just fell in love with the program and the city, and were completely caught off guard, and our families thought we'd lost our minds. But we ended up just absolutely loving that program. And so we listed that first, followed by a whole bunch of Florida programs, and were lucky enough to get our first choice and end up in Charlotte, North Carolina.
Oh, congrats. That's amazing.
It was like I said, our families thought we were crazy. They're like, who are you people? You weren't supposed to ever leave Florida.
Yeah. What do you think set you apart the most as an applicant? Was there anything in particular that was a constant thing that came up in your interviews?
For me personally, I had gotten involved knowing, once I decided that earlier in medical school, like we talked about, I was kind of torn between peds and surgery. And I also really liked global health, and I liked procedures. And so I kind of joined a lot of clubs and got involved in a lot of different things. And so my resume had a lot of different positions on it. And so I think that was something that came up over and over in my interviews. I was really involved with the Students' Interest in Global Health. I had done some work with the Pediatric Interest Group. I'd done some work with the Surgical Interest Group. I'd done some work with the American Medical Women's Association, and was actually the national recruitment chair for the American Medical Women's Association for 2 years. And so I had all these other little things kind of going on in the background, which kept me very busy, but ended up being really good talking points during interviews.
Oh, amazing. At what point did you know that you were going to go into neonatology?
As soon as I picked peds, I was pretty sure it was going to either be NICU or PICU.
Okay.
And from there, I kind of waited until residency to make that call.
Okay. And what kind of drew you more towards the NICU?
Several things. One, I just feel more in control when I'm in the NICU. There's always a lot going on in the NICU, but at the same time, it's also very quiet. The babies, they're trying to die all the time. And so you kind of get used to it. And there's less chaos, I think, when people's oxygen levels drop and people's heart rate drop. People respond appropriately and big things happen, but nobody's running around. I also really liked the pathophysiology that I saw in the NICU. I thought it was really, really interesting, the transition between fetal life and extrauterine life, and kind of going through some of the physiological adaptations that occur during that time frame were just really fascinating to me. I also have a really hard time with when parents bring in kids' little league pictures into the PICU, and they put up their school dance or their father-daughter dance on the wall. That just really hits me a lot harder and makes me have a harder time focusing.
Yeah. I feel like NICU it's always just it tears at my heart, because it's you get
in there.
Yeah, you have the sickest baby. So how do you, I guess, keep up your spark, when it's so challenging?
It's very different. It's very weird, I gotta say. In the NICU, you're right, we have super sick babies and super sad families, but we also have these amazing miracles that happen. And so I think one of the hardest parts of my job is flipping back and forth as I walk from bedside to bedside. So you go to one bedside and you sit down and you give them this terrible news, or tell them that their child might not survive. And then you go to the next bedside and like celebrate that their baby who was born at 24 weeks is going home next week. And you have to be genuinely happy with that family. And so I think that's really the hardest part. I think you hit the nail on the head there. The way that I try to look at it is that the patients that come to me, they started out super, super sick. And so whatever time we can give that family, whether it's a couple days or a couple weeks or getting that baby home a few months later, is all time that they wouldn't have had without just the amazing things that can happen in the NICU. They were never, when I think about it compared to the PICU, those kids have been out there living their life, having all of these wonderful memories, and then some terrible thing happens and it's just potentially ripped away from this whole family. And that's a lot harder for me to process. Whereas when I think about the NICU, I think, man, these babies were really starting from pretty dire straits, and whatever time that we can give them, whatever opportunities we can give them, were things that they wouldn't have had otherwise.
Yeah. And how would you describe your day-to-day, since you're working at the largest NICU in the country, right?
It's big. It's a big place, yes. I think we are either the largest or the second largest NICU all under one roof. We can hold more than 140 patients at one time, and have a lot of pretty high acuity babies at any given time. My day is a little different than some of my coworkers' days. I'm actually part of a team of 3 to 4 physicians amongst my colleagues that take care of the babies born at 22 to 24 weeks.
Mm-hmm.
And so I spend a lot of time on the more acute side of our NICU, rounding on, we have anywhere on any given day from 8 to 12 patients on that service, on the tiny baby service. And so I spend the majority of my day there, and then we'll follow some of them downstream as they kind of graduate from that tiny baby program and get closer to discharge. Most of the day, every NICU works a little bit differently. In more academic settings, an attending will round with several residents or nurse practitioners who have rounded on each baby, and kind of oversee several different people's work. Where I am at Winnie Palmer, we don't structure our day that way. Each patient that I round on independently. I examine independently, I put orders in and write notes independently, as opposed to kind of overseeing several people doing that work themselves.
Okay.
I really liked that coming out of fellowship, because I felt like it would give me a chance to hone my clinical and bedside skills a little bit more, as opposed to kind of overseeing several other people. And so when I get to work, after sign out, I basically just jump right into those level 3 little sick tiny babies and jump right in, start seeing them. We do some group rounding with pharmacy and nutrition. We do have some residents in the NICU as well that work with us. And then from there, kind of bounce back and forth between procedures, deliveries, writing notes, updating families, before calling it quits at the end of the day.
Okay. What was your transition like from fellowship? I feel like, fellowship, you're still kind of, you have people overseeing and stuff like that. So how did you feel when you were just kind of like, you are the top person, you're on your own?
It's terrifying. Something major happens and you kind of look around like, oh, it's me. I have to answer that question. Okay. But actually my coworkers were great. I joined a pretty big group. I think there's about 18 to 20 of us total, and kind of a variety of levels of experience and time spent in this NICU or other NICUs in general. And they were really phenomenal. They were always there if I had questions, and came to me kind of independently to be like, hey, you got anything big going on? Can I help with anything weird? And even now I've been there a little over a year, and still will just kind of grab people in the hallway and be like, hey, can you listen to this? This is what I was thinking. Any other ideas, guys? And so I think having a good group of people that are willing to support you as part of your coworker pack is critical, because there are moments that I just felt completely blindsided, and loved being able to kind of depend and lean on those around me as well.
Yeah, like getting a second opinion and stuff like that.
Exactly.
That's awesome. And how would you say, how many patients do you take care of at a time when you're working at the hospital?
Um, Most days I probably round on somewhere between 12 and 15. Weekends, or if someone calls out sick or something like that, there have been days that I've seen up to 18 to 20.
Oh, wow.
It kind of varies too, depending on acuity, because I tend to take care of those tiny sick babies. Oftentimes I'll maybe see 2 or 3 less than my coworkers who might be seeing some more kids who are getting closer to discharge, a little bit less acute. But I'd say usually on average about 12 to 15.
Okay. So now that you're expecting, I'm not sure when you started and like if this is your first baby, but
It is my first baby. Yes.
it is your first baby. Congrats.
Thank you.
Has that, I guess having a life inside of you, has it changed your perspective as you're caring for, these tiny sick babies?
Yeah, it's terrifying. The whole thing is just terrifying, I gotta say. So for me, it was not too bad until I hit kind of that viability mark, that 22 and 23 weeks, because before that I knew, like, no matter what happened, there was, limited options. But once I hit 22 and 23 weeks, it got to be really, really stressful, especially when I got called to those 22 and 23 weeks deliveries and I'd be intubating a baby whose due date was after mine. It kind of put a whole new perspective on things. It also, sometimes I feel awkward. I gotta say, talking to families whose babies came so early, and now I'm almost 31 weeks and they're sitting there with their 23 weeker fighting for their life, and I feel very grateful but also kind of guilty and awkward.
Yeah.
But I mean, the families have been great. They're all super supportive. It's not like anything, no one's ever said anything, but I think I carry a little bit of guilt that I've been able to carry longer than many of them have.
Yeah. And when you're rounding on the babies, I guess, is there any certain cases that you, I wouldn't say enjoy doing because, you have the sickest of the sickest babies, but is there any conditions that I'd say that you are fascinated by the most, or you enjoy taking care of the most?
Yeah, I love the tiny ones. The tiny ones are right where I want to be. Many of my coworkers are more interested in babies who've had hypoxic ischemic injuries, who might be cooling or have some neurological insults. We all kind of have our niche, and I just love the teeny tiny ones that were born like 22 to 25, 26 weeks. For me, they're very complicated. There's a lot going on, a lot of detail oriented things, which is really kind of my favorite way to think about medicine, is get super detail oriented. But the other thing that I really like about the super tiny ones is that there's so much math, and I find that to be really reassuring to me. When I'm stuck making a tough decision, I can fall back on math and numbers and weight gain or weight loss or the change in sodium and the urine output, and all of that can help me kind of build a case for the decision that I'm making, and it makes me feel more confident in my day-to-day work.
Okay. What's the most difficult aspect of your work?
The hardest cases for me are the term babies, the babies who were born close to their due date, who were supposed to be fine, and something either went wrong at the last minute, or there was an undiagnosed prenatal anomaly that I feel just blindsides families. And that may also be part of why I like taking care of the premature babies. I feel like the parents kind of know what they're walking into, but the term babies who are super sick are really challenging for me. And then, as I mentioned before, kind of that flipping back and forth between grieving with one family and celebrating with the next family next door. It's a different kind of stress, because you have to really mean it or they'll know. You have to really celebrate with that family, and then you have to be very sincere when you're talking about end of life care with the very next family. And so it puts a lot of strain on your emotions. I think you have to be able to kind of bounce back and forth between a lot of different feelings.
Yeah. And how do you manage with the parents that are very anxious or like blindsided? Because I'm sure, the babies one minute they're stable, the next minute they could not be. So how do you handle those situations?
I think there's I think you just have to be honest with them from the beginning. Even with the tiny babies, I tell them, we're never out of the woods. I will always tell you how your baby is doing. I will always be honest with you. And if things are going great that morning, then that's wonderful, and that's what I'll say. But that doesn't mean that things are going to be going great the rest of the day. I try to, especially with the babies who are very unstable or very sick, warn families that things do, exactly like you said, change very, very quickly, and that the best that we can do is respond to those changes as quickly as we can and update them as quickly as we can. But I think just being completely honest is the only way to get through it.
Mm-hmm. My next question was kind of how the pandemic has impacted your practice in particular at Winnie Palmer. If you could talk a little bit about that.
Absolutely. So the pandemic is a bummer. It's not our favorite. In the ways that we've changed our practice have been kind of three main areas. So first, we obviously, when we go to deliveries, that's really our highest risk time that we might encounter a COVID positive patient. Usually it's mom or dad as opposed to baby. And so we have changed our practice model a little bit so that we have a scheduled delivery person most days who can be carrying around an N95 mask if we need one, have their goggles in their pocket, things like that. Whereas before, it was the person on call often went to deliveries. And so if you were in the middle of rounding on someone, you may not have all of your equipment with you. So we had to develop some different protocols as far as responding to that to try and protect ourselves. And then the second aspect of that is that we had to develop a plan to test our patients. And so when a patient is delivered and admitted to the NICU that was born to a COVID positive parent, they have to go into isolation, and then we have to test them every 24 hours for, right now it's 2 days. And if we get 2 negatives, then they can come out of isolation and life's great. We've actually, fortunately, not had a lot of patients that ultimately tested positive, which has been very convenient.
Okay.
But I think the hardest part for the NICU in general is that we've had to really, really limit visitation quite a bit. And certainly we were already pretty picky when it came to how many people could be at the bedside. But historically, for example, if you had a baby born, mom and dad would each certainly be able to visit. And then at different times, we'd allow up to 1 or 2 other individuals, grandparents, to visit. For example, we only allowed 2 people at a bed at the bedside at any given time, but parents could have these additional support figures involved in rounds, involved in care, and to be there to support both them and to meet the baby, especially when the baby was sick. And now we at Winnie Palmer only allow the parents to visit, no additional family member, and that's even more lenient than other NICUs across the country. Some completely had to cut out visitation and completely, even for parents. Some have limited it to 1 parent. And so you can imagine that adds a whole nother layer of stress to the families. When you have a baby in the NICU, especially if you have a baby that's going to be in the NICU for months and months and months, we know that there is a level of NICU PTSD. It is absolutely real. You hear the beeping in the middle of the night from the monitors, even when it's long gone. It can disrupt your sleep, and it can last for a really long time. And so having additional family members there to support you helps to alleviate a lot of that stress and a lot of that burden, and can make family feel a lot more comfortable. If mom, for example, has to go back to work or has another child she has to care for, she was able to lean on additional family members previously to be at the bedside and to be checking on her baby when she couldn't be. And now we can't allow that because we have to limit it so much. And that's been really, really hard on our patients' families. And it's really hard, they come to us and they want us to make exceptions, and we can't do that. But I think that's been the toughest part for us, is really having to take that level of support away from our patients' families.
Yeah. Do you foresee that changing with the vaccine coming out?
Probably not for a while. Hopefully, yes, eventually. But looking at some of the timelines that they've published about when the vast majority of the population would be able to be vaccinated and when we'd get to a point where there was a certain level of herd immunity, I think we're looking probably at least 6 to 9 months from now at a minimum.
Okay, because I know that with the vaccine now, even pregnant women are considering taking it. So I think that it'll help, with time.
I do too. I do too. My husband actually got it this morning. Yay!
Oh wow.
So he went 7 o'clock this morning and got his first dose, as well as several of my coworkers. So we're very lucky to be in a time when something like this could have been developed so quickly and rolled out so quickly. And I think the hospital systems are working really hard to try and get it to their frontline workers as fast as they can.
Mm-hmm. Do you foresee yourself getting the vaccine? I know that since you're expecting, it's like
we've gone back and forth a lot, actually. I've talked to my OB, I've talked to some of my pharmacy friends, and part of it for us is timing and my job. And so we are leaning towards me getting it right after I deliver in February, because I'm about 31 weeks now. And so for me, by the time that I conferred antibodies to the second set of the second shot of the series, it would basically be time for me to deliver. And so I don't know that there would be a whole lot of additional protection in starting it now, as opposed to just kind of the risk of the unknown, even though on paper it doesn't really look like it should be much of an issue. I think if I was earlier in my pregnancy, I would actually be more likely to get it, because I think I would have more time where that would protect me. Or if I was in a job where I was more on the front line, seeing more adults in the ER and the adult ICU, then I would more seriously consider it. In the meantime, Patrick will get it. And then most of my coworkers are getting it, and then we're hoping that I'll hopefully be able to as soon as we deliver.
Awesome. I know that since you know the whole process, like the pregnancy process and everything so well, I figured that you would have very meticulous thought process to it.
Yeah, it's I keep hoping that they're gonna magically come out with all of this data tomorrow and tell me officially that it's safe. And when I talk to some of our pharmacists about it, logically, the way that it works, the mRNA component of it, it shouldn't really have any effect. And so I think that if I was in a riskier job, I would probably, the risk of the unknown from the vaccine versus the risk of the unknown from COVID. If it was a longer time period, or if I was more likely to encounter COVID in my work life, I think I would probably just go for it and get the vaccine. The timing, like I said, it's not going to get me a whole heck of a lot by getting it right now.
Yeah. Well, thank you for sharing that.
Yeah, of course.
My last question was, so with all the schooling that you've done, and now with all the experience that you have working in the largest NICU in the country, what two golden nuggets can you offer a med student or somebody that is interested in going into neonatology?
Well, first, whether you're interested in neonatology or interested in medicine in general, the most important thing that I can say is that you have to love it. You have to really, really want it. And not just because it's this prestigious job, or you're going to be a healthcare hero, or you think you're going to make all this money, or whatever it is. Being in medicine is a real commitment, even beyond just your general 9 to 5 work life. It permeates everything, between being in training for so long, you come out of training and all of your friends are also in medicine, so you have nothing else to talk about, and then how it even affects your work-life balance and your home relationships. I do not regret for a second going into medicine or going into neonatology. I absolutely love my job, but you have to love it or it's not going to be worth it. I think that's the most important piece for both my husband and I. We both love what we do. And so sometimes you do have to make some sacrifices, like moving around while you do residency and fellowship, and kind of putting your life on hold a little bit, until you get to the point where you can choose where you want to be and how you want to live your life. But if you love it, then at the end of the day, it all ends up being worth it.
Yeah.
And then Beyond that, I think for women in medicine in general, whether you're in medicine, med school, or trying to get into medical school, or if you're looking at going into a field like ICU or surgery, I think you just have to remember that you deserve to be there just as much as anybody else, just as much as the next guy, and be willing to advocate for that and for yourself. And sometimes you have to remind people that you're just as qualified as everyone else.
Yeah.
But I think knowing that you love what you do and knowing that you have a right to be there are critical.
Oh, that's so good. Thank you so much
Of
for
course.
for taking the time to interview and sharing all your experiences, especially now that you're expecting. Congratulations.
Thank you.
Wish you the best, and I really hope that COVID disappears sooner rather than later.
Me too. Me too. That would be great.
Okay, well, happy holidays.
Thank you.